Good morning. Thank you for the introduction. Oops, sorry, let me go back. Sorry. So what I will be talking today about strabismus in the pediatric population. I just want you to know that strabismus is a huge topic. We could talk hours of a type of strabismus. So this is going to be very summarized talk about a little bit of the language that we speak, a little bit of why we do what we do, and management. There we go. So what is strabismus, right? Strabismus is misalignment of the eyes. It's the fancy term for misalignment. So we can drift out, we can drift in, we can drift up and down. And basically just know that it is normal for babies to drift up until they're like around 4 months. So sometimes we get those referrals, but it is completely normal. It is after that time that we have to, we really have to see those children and evaluate them. So just so you know, we know exactly where the eye muscles are, and we have 7 muscles around the globe. So strabismus can be classified in different ways, but this is a nice one, which is basically you have congenital strabismus, which is basically you're born with the condition and you can drift in, you can drift out. You can be born with a 3rd nerve palsy, 6th nerve palsy, 4th nerve palsy. And then you have syndromes, which are Duane syndrome, Brown syndrome. And then you have acquired cases of strabismus, which is basically all the congenital ones, we can get them afterwards. If you have a bad head trauma, if you have a stroke, for example, right? And then you have other types of strabismus, which are acquired, which could be due to a high refractive error, due to an orbital fracture, due to muscle conditions like myasthenia gravis, or thyroid conditions can also affect your muscles. So if you look at our notes, you're going to find all this terminology, right? We have esotropia means turning in, exotropia turning out, hypertropia turning up, and then you're going to have you're going to see our notes have abbreviations. We use ET, XT, HT, and then to make it a little more complicated, if you put the T in parentheses, that means that the deviation is intermittent, meaning you don't see it all the time. A term that we should all be familiar with is orthotropia. Orthotropia means when we're aligned. So basically that's normal. And then you will hear us say, talk about a comitant versus an incomitant deviation. This means that, and we'll see further along, when we have someone who's drifting, we have to measure that misalignment. And we say it is comitant when that amount of deviation is the same in different gaze positions, including distance and near. And it is incomitant when we have a different measurement, meaning we have an example would be you're drifting 50 prism diopters at near and only 20 at distance. That would be an incomitant deviation. Then constant, we all know what that means, and intermittent, meaning the patient is drifting, but sometimes the patient is straight. So it doesn't happen all the time. That's when we use the parentheses that I was talking about. And then alternating means, especially in babies, this is important that parents come in and they're like, okay, the baby's drifting the right eye. And that actually tells me that the left eye, for example, has good visual acuity and the right is a little amblyopic or has a little bit of a lazy eye. So when we see alternating, that's actually good because that means that more or less the patient has the same vision in both eyes. Again, this would be a patient drifting in, right? Clearly drifting out, the one in the bottom. Here you see a patient that is actually fixing with the right eye, and we see that when he's fixing at distance, that left eye turns up and out, right? When we have him, if you look at the pictures up at the top, when that patient is looking to the right, we see that the left eye is kind of going up a little more. That's called inferior oblique overaction. Right, and when the patient looks to the left, the eyes are aligned. And then if you look at the bottom, I do a head tilt test. And we see that when I tilt the head to the right, the patient is straight. When I tilt to the left, you see that left eye going up, right? So all these together is basically congenital superior oblique palsy, which is that little, I don't have a pointer, but that little round, the smaller muscle is the one that is affected in this case. We see here a patient that has an esotropia, so a baby that is drifting in. And if we see when we make him look to the right and to the left, both the inferior obliques are overacting. So you see an eye that goes up a little more. That's because the inferior oblique, one of the muscles, is actually acting a little more. That's why the eyes go up, right? And this all together goes along with congenital esotropia. And the importance is to get everything together. So babies, we are very difficult to examine. So sometimes the first visit, we're just going to see the horizontal deviation. And then we see them often in order to be able to get everything together. Because if I take this patient for surgery to align him in the horizontal way, the aspect, then if we know that he has an inferior oblique overaction, we should do everything in the same surgery. To make it a little more complicated, you will hear about pattern deviation. So sometimes we have patients that have, for example, this one, when you look at the middle picture, the patient's looking straight. That's what we call primary position. And the patient has a small exotropia or drifting out. But when she looks up, she's fine. She's ortho. And when she looks down, we have a little more of an XT. So this is, if you trace a line, this looks like an A, right? So this is going to be a patient with an A pattern deviation. If it's the opposite, it would be a V pattern. And then we have different ones. We have when they're misaligned at the top but straight at the bottom, which would be a Y pattern or a lambda pattern if it's the opposite. If you see this patient here, right, this patient is referred, this is very common referral, referred by pediatrician for drifting in. And if you look at this child, you would say, oh yeah, I think you're right, drifting in a little bit, right? If you look at this one's clearly drifting in, you have no doubt, same as this one. But I'm going to tell you the first patient is actually aligned. This is very common. This is called pseudoesotropia. Pseudo because it looks like if he's drifting, but he's really not. This patient is straight. And we can all, in the clinic, and you guys can do this as well, we shine a light and we basically look for the corneal reflex. The light, if you look at the one on the top, you see that that reflex of the light in the cornea is actually right at the center of the pupil. This patient is completely aligned. If you look at the bottom ones, again, a patient is drifting in, for example, or drifting out, and he has to focus, he has to look with one of the eyes. So in all of the cases, the right eye is aligned, but you see that that little reflex that we were shining the light at is actually, you don't see it at the center of the cornea. So these, the last three are actually drifting. And this is a very easy test. It's called Hirschberg test, and we could just do even with a phone light. So again, if you look at this child, we did the Hirschberg test, right? And you see that that reflex falls exactly at the center of the pupil. So this patient is aligned, okay? Why does it look like if he's not? Because he has a baby face. He has what we call the white nasal bridge. And if we have extra skin here, it looks like you don't see the white portion of the eye. So it's like an illusion. It looks like if he's drifting. So we have a patient that comes in referred for strabismus, right? Or that we find has strabismus. What are we supposed to do? We have to do a complete eye exam. Of course, just like anything else in medicine, we have to get a good history. It's going to help us to know, in our head, we're going to start doing that classification of congenital acquired. If we know if it has this been there since birth, did it start 4 months ago? Do we see it all the time? Not all the time. Is it intermittent versus constant? Or did it start 2 days ago? That's a little more worrisome, right? Family history, double vision. I don't usually ask this in little children because sometimes they can't tell, but it is helpful in older kids. Family history, just know that strabismus runs in families. So there is a genetic component as well. You see this little kid here came, his mom was perfectly aligned and this was his grandmother, right? So it runs in families. Always ask if there is someone else who drifts. As soon as the patient comes in the room or we walk in the room, we start looking at abnormal head positions, right? Sometimes if we get too close to a child, they start yeah, they don't like it, they start crying, but as soon as we see them, it's going to help us. Sometimes they have an abnormal head position in order to compensate the deviation. So we can see head turns, tilts. What we call chin up is when they walk like that, or chin down, when it's easier for them to look like this. So this is something that as soon as you walk in, we can have an idea, and sometimes it's very obvious. Of course, the visual acuity, and we know that in children it can be very difficult. We have Snellen, but we also use other methods like pictures, which is Allen, HOTV. We have preferential looking in babies, and in very young ones, we sometimes just have to make sure they track with each eye covered. Stereo acuity, we have different types. The one we use here is the Fly. We have the Lang, we have TNO. I personally like the TNO because it quantifies a little more, but basically just know that this is a test to evaluate depth perception. So sometimes it's important to do it in every visit, because if we see that stereo acuity is going down, this is a time when sometimes we have to talk about surgical correction. Gaze position. So we have to evaluate not only in the primary position, which is looking straight ahead, we have to evaluate the patient in different gaze positions to see the alignment. And to see, this is going to help us to see if it's a comitant, a comitant or an incomitant deviation. So if we look here, this patient is actually looking nine gaze positions and he's straight. Why is this important? I'm going to show you this patient. This patient is actually ortho in primary. And if she looks down, she's straight, looking down and left. She's doing all this look good, right? The patient has no deviations. If you look here, when she's looking to her left, kind of off, we see the right eye is going down a little bit. Now, when she looks up, we clearly see the misalignment, right? And then when we have her adduct the right eye, we see that there's restriction of elevation in that field. And this is actually Brown syndrome. So we would have missed this if we hadn't checked this patient in the different gaze positions. We always do a red reflex. This is a very easy test to do, and you can all do this in the clinic. Basically, with an ophthalmoscope, you check the reflex in each eye. This is done individually, and then you see that patient up at the top. It clearly has a normal red reflex, and then you have the very abnormal ones, but then you have a range, and this is when a lot of pediatricians sends us patients for an abnormal red reflex, because it could be a little difficult to differentiate sometimes. Bruckner test is basically the same as the other one, as red reflex, but you just jump back a little bit and you try to see both eyes at the same time in order to compare. Hirschberg test is the test that we talked about, looking at the reflex and making sure it falls. If the patient is orthotropic, which is aligned, basically it's going to fall at the center of the pupil. Very easy test to do with any light. So once we have the patient that we know is drifting, right, or we want to evaluate for drifting, we do a cover. We cover and uncover the eye, and we're going to see the movement of the eye. And then we do the alternate cover test, and this is with the patient fixating at distance and near. And then when we start, we have to measure the deviation, right? We have to quantify it. So we use prisms. I personally like the individual ones, but you have bars as well. And you basically cover the eyes, alternate covers the eyes, and you see the movement. You start putting the prisms until that drifting stops. And that's when we know the amount of prism diopter deviation the patient has. In babies, which don't cooperate they're not going to fixate when we tell them to, or patients that are developmentally delayed, we use Krimsky test, which is basically we do the Hirschberg test, which is shining the light and looking at that corneal reflex. And we start putting prisms until, if you see the picture, I don't have the pointer again, but if you see the picture at the bottom, until that reflex falls exactly at the center, which in this case was with a 50 prism diopter in one eye and 30 on the other one. So this patient has an 80 prism diopter of esotropia. We always dilate, and if you have to take something from this class, is that we always dilate a patient that comes with a deviation. Why? One, because we have to check the need for glasses. This is part of the treatment for strabismus, but we want to make sure there's nothing in the eye that is causing this, right? So we can have a corneal opacity, we can have a cataract. Patient would have to get cataract surgery for that. We can have a retinal scar. but you don't want to miss this. This is a retinal blastoma, which is basically cancer. And we can save the patient's life if we diagnose this early. So a patient does not leave the clinic if they come with, the either referred or the parents concerned for drifting of the eyes. A little bit of management. Again, we said strabismus. We have different types of strabismus. Each strabismus has, some specific things, but just know in general, when we have a patient that is drifting, glasses is the first thing we have to do. So we have to check the refraction, just like we said, and give them the correction. There is a condition which is called accommodative esotropia, which is a patient comes in drifting. We check the refraction, and we know children are supposed to be farsighted. That is normal. But if we have someone who is high hyperope, so if this patient is a +6, +7, we give them the full optical correction, and then he comes in 4 months after using his glasses, and he's completely straight. So this is one of the treatment we use. Patching, because if we have, as we said, if we have a baby who is not alternating, meaning we're always drifting the same eye, that tells us that the visual acuity is off. So we have to give glasses, and we have to make sure the visual acuity gets better. Why? One, because we want him to see better from that eye, but two, because if we're going to take that patient to the OR, we know that the outcome of the surgery is going to be much better if the visual acuity is good in both eyes. So patching is very important. Botox, we don't use this much here, but just know that it is a treatment. Basically, we know what Botox is, right? And it basically paralyzes the muscle and relaxes the muscle. I worked in Argentina a lot. We had waiting lists for congenital esotropia. For them to get the surgeries, that would be 2-year wait list. So Botox would be what we would use until they got to surgery. And then surgery, right? Basically, again, multiple types of surgeries, but just know that in general, what we could do is to the muscle, we can weaken the muscle, we can strengthen a muscle, we can cut a muscle, we can cut a piece of the muscle, we can elongate a muscle. So there's different things we can do. But the most common surgery that we do, I think, would be weakening or strengthening the muscles. This is what a patient looks after surgery. And just a little bit, just so you know, what we do is we know exactly where the muscles are. We know which ones we're going to operate and where to find them. We open conjunctiva, we look for that muscle. We use hooks for that. So those are the hooks. Then we actually secure the muscle with vicryl sutures. This is because we will cut the muscle. We will disinsert it from the globe, and we want to have that, we don't want to lose the muscle. So that's the reason we secure before cutting. Then we use calipers, and this is the importance of a good clinical examination to get the right angle. So when we measure the patient, then we use tables to see how much we're going to do the recession, for example, in this case. We mark with a caliper, and then we secure that muscle at the new spot. So if you look here, this is the original insertion of the muscle, and this is what we recessed. We secure the muscle to the globe, and then we close conjunctiva. Basically, that is the surgery. And that's all I got. Thank you very much.
So yes, good morning, everyone. Thank you for your time and attention here. Yeah, my name is Quingie Wang. Thanks for the opportunity to give this a brief summary about diabetic retinopathy. So basically, this is my outline for the presentation for the day. Basically, start with talking about epidemiology, talk a couple risk factors associated with diabetic retinopathy, along with a simple touch on the pathogenesis, different stage of diabetic retinopathy, and associated complications with this condition, and basically conclude with a diagnostic approach and treatment options. So that's the outline of my talk today. We can advance to the next one, please. Okay, so basically talking about diabetic retinopathy is a significant burden, not only in US, but also across the world. So there's quite a few academic research. They talk about the prevalence of diabetic retinopathy For example, in this article published in JAMA, I believe they mentioned, at least back then in 2021, there are like almost 9.6 million people in US. They were diagnosed with diabetic retinopathy. And on the image on the right side, that basically showing across the world, depending on which location or region or country you look at, certain country has also higher rate of population being impacted by diabetic retinopathy. We can also advance to the next slide, please. Okay, so this is the JAMA ophthalmology research I mentioned about published in 2021. So this basically showing in US specifically across different age group, from like teenager, young adults, adult, and also seniors, and what's the percentage of population being affected by diabetic retinopathy. This is basically talking about diabetic retinopathy across all different stages, and there are different color indicating their ethnicity background, but we don't have to go through those details. We can just go on to the next slide, please. So this is the same study. They talk about again, like for different age group, how was the percentage of patients they were diagnosed with vision-threatening diabetic retinopathy. Again, now you can see the trend here. Typically, for like age, starting from I'd say like around 40 all the way up to like 70, 75. That's the age group. They tend to be affected by that diabetic retinopathy with more like vision-threatening stages. Again, they did study for different ethnicity. So this one basically talking about again in US distribution of diabetic retinopathy. This is just across multiple states, different color indicating higher, I guess, a proportion of population being affected by this condition. I guess the darker color indicating more population being affected by this. And we can move on to the next slide. So again, this is a similar statistic, but again, focusing on vision-threatening stages of diabetic retinopathy. It's similar pattern, just quick overview. We can move on to the next slide. So what are the risk factors for diabetic retinopathy? There are quite a few of them, of course. How long patient being diagnosed with diabetes, if they're type 1 or type 2 or not. Type 1 tend to have higher chance to develop diabetic retinopathy only because they start at early age, sometimes not getting like quick diagnosis. They tend to have higher demanding with ischemia and inflammation from this condition. The other thing would be fluctuation of the blood sugar, which you can reflect from the finger stick measurement of patient using the monitor that they can tell, and also per A1C control. One of the main risk factor is actually hypertension. So we always say there's a synergistic effect with both hypertension and high blood sugar. So those two work together, give more problems. And high cholesterol also being implicated, obesity, which goes along with above risk factors. One key factor here is actually pregnancy. Basically, for patients who never been diagnosed with diabetes, they can develop diabetes during pregnancy. And for patients who were diabetic, being pregnancy can further increase the risk of diabetic damage, including diabetic retinopathy. And other potential factors can be modified, such as smoking, alcohol. Those also can contribute. We can move on to the next slide. Yes. So I'm going to quickly touch base on the pathogenesis of diabetic retinopathy. So diabetes is basically, in my opinion, is a vascular condition. So often due to change to the blood vessel, the vessel can become leaky because of uncontrolled blood sugar, and you have cell loss, you have tissue loss, you got inflammation that drive a bunch of different cytokines that they cause further focal ischemic damage, and eventually, they try to recruit new growth factors, trying to develop new blood vessel. At least in retina, that can happen, but in other part of the body, like in kidney or in nerve or other part of the body, that's a slightly different mechanism. But at least in retina, when we talk about diabetic retinopathy, the abnormal new blood vessel formation is basically one of the key event which can happen at later stage. But put together, simple enough, there's ischemic burden, there's a persistent inflammation, there also will be basically a leakage, meaning the barrier between the retinal tissue and the blood vessel being compromised. So all the factors, they're working together like a spiral pattern, eventually driven the pathogenesis of diabetic retinopathy. We can move on to the next one. Okay, so regarding the stages of a diabetic retinopathy, though many study has been done this back to like 30, 40, 50 years ago. So we typically, the current model, we stage from like no sign of diabetic retinopathy towards mild non-proliferative diabetic retinopathy to moderate the severe. So those are non-proliferative diabetic retinopathy. Afterwards, we basically escalate to proliferative type of diabetic retinopathy, which can be early or severe, and there are different features to define individual stage. I don't really feel like we need to go through all the details here, but knowing that there are three major subgroup, like no diabetes, non-proliferative diabetic retinopathy, or proliferative type of diabetic retinopathy, and they all need different attention, or visit pattern, and also intervention depending on what's the indication from the complication. We can move on to the next one. So yes, basically talking about complications of diabetic retinopathy. Typically, there are a couple indications need treatment or intervention. So often commonly we see patients present with a diabetic macular edema, meaning the retina, specifically within the macula, they develop fluid. This can be within the retina or underneath subretinal space. So depending on the visual acuity, depending on the appearance of the macular edema, typically you triage, you decide if patient need intervention or not. And along the line of diabetic macular edema, patient can also develop hemorrhage. This is typically when patient further progress into the proliferative stage. So they develop abnormal blood vessel, which can present in the iris, which basically called rubeosis, like the upper right photo that showing rubeosis. There are abnormal blood vessel developed within the iris that can increase risk of what we call neovascular glaucoma. They can have increase of hyphema. And for those patients, if you put a gonial lens, look at the angle, sometimes you may identify neovascular glaucoma of the angle, which is another indication of treatment. And of course, they can bleed in the back, in the vitreous cavity, like the left lower image, bowl-shaped pre-retinal hemorrhage. That's basically from proliferative type diabetic retinopathy. There's bleeding, and the bleeding can be focal, can be contained, or can be really spreading out. Patient totally lose their view, and eventually, for persistent chronic inflammation, patient can develop fibrosis. They develop very tough membrane. They cause focal traction, and those traction can eventually causing retinal detachment, and that of course need a treatment as well. I think I have another video which we may not be able to show. It's a video basically just showing ongoing bleeding from the abnormal blood vessel. We can give it a try, but it may not even plate. That's fine. We can move on to the next slide. Okay, so what are the common diagnostic approaches to stage or diagnose diabetic retinopathy? Typically, we start from the with our own eyes. We look the fundus with either indirect or with a slit lamp, and we can tell there's hemorrhage, there's no hard exit, there's cotton wool spots, there's ERMA, there's abnormal blood vessels. So those we can see directly. Of course, we all need our ancillary amazing staff member to help us to obtain further imaging workup, this including OCT, especially looking for macular edema, and sometimes OCTA to further define or stage the diabetic condition. We use optos a lot. Basically, you want to get wide view, like the right top corner image, like the typical optos photo. You see in the center, there are a couple white circles. I believe there are 7 of them. So those basically represent the region or the focus of imaging in the past before the wide view image system being available. So back then, when diabetic retinopathy study was carried out, the main focus is the posterior pole. So that's the 7 image classically being obtained to quantify or classify the diabetic retinopathy. But nowadays we have access to optos photo. We always try to get the whole fundus view to further define not only just in the posterior pole but also beyond in the mid-periphery and also in the foreperiphery. And of course we need fluorescence angiogram. That's a lower right image, basically an example of a proliferative diabetic retinopathy. So fluorescence angiogram, this is pretty essential, in my opinion, for retinal practice, especially for diabetic retinopathy. You can really look for abnormal blood vessel formation. You can look for capillary non-perfusion. You can look for local leakage. You can identify a lot of features, and those features also guide us for treatment, especially when it comes to laser treatment. Knowing where those abnormal blood vessel locates is very helpful, so you can really treat those focal spots along with PRP, of course, which will touch base. Okay, so now moving on to treatment options. So of course, as I said in the past, there are different stages of diabetic retinopathy. Patients typically start from background, meaning mild, non-proliferative type, and even for moderate and severe, depending on if they have significant macular edema or not. Often they can be just monitored. Of course, you obviously encourage patients to have good blood pressure and blood sugar control. You have to make sure they talk to their primary physician, also their endocrinologist. If they need a pump or anything, we would advocate for the patients. So lifestyle modification, this and that. For patients present with clinically significant macular edema affecting visual acuity significant enough, we do recommend anti-VEGF to begin with, which has been shown quite effective to treat and manage this type of condition to preserve good visual acuity. And for patients who have been refractive to anti-VEGF, there's always availability with intravitreal steroids, such as I just blanked on my mind, but there are quite a few of them available. You can put in, they provide long-term effect. They help with the swelling of the retina. And for patients who have proliferative type of diabetic retinopathy, especially the severe one or high-risk one, we do recommend patients to get pan-retinal photocoagulation. That's basically a laser. You treat the peripheral part of the retina. You do not want to touch the posterior pole. The goal here is to preserve the visual acuity intact for the center and to limit the ischemic burden coming from the peripheral retina. And we do this all the time. Focal laser still being used. It's a really good approach modality to treat a patient with macular edema. I think before anti-VEGF being available, focal laser was the way to go for the most part, but nowadays still being offered here and there, but mostly being replaced by anti-VEGF injection. of course, surgical intervention for patients who have non-clearing vitreous hemorrhage, or they have macular-involved tractional retinal detachment. You have to bring patient to OR and perform vitrectomy to treat the condition. So that's for that. And again, just put a quick summary slide here. Depending on the stage of diabetic retinopathy, starting from patient having diabetes but no diabetic retinopathy, all the way into proliferative type with different risk factors. Patient follow-up pattern, how often you're going to see the patient. It start from like once a year to like every couple months, every few weeks, and injection or laser or surgical intervention. It's all depending on the stage of the condition, which is that's my quick reference here. And for now, I think I will just stop here, and happy to take any questions. And thank you for your time and attention.
All right, we've got that taken care of. So for today, what I would, I've given many lectures, but they were mostly to the residents, and they wanted to know about OR surgical problems. So when I started putting this together, I had to keep remembering who my audience was, that you're based in the office. So I hope that I was able to put that together for you. Okay, so initially, where do patients come from? Okay, the majority probably come from other offices, ophthalmologists and optometrists, but dermatologists refer a lot, endocrinologists for thyroid disease. So patients can be referred from anywhere. Many will self-refer. They know somebody who's had surgery, or they look you up and they come in for either functional problems, but more and more, they're interested in cosmetic solutions. And some, of course, may be follow-ups for long-standing problems. It's important to remember that you're the first person that the patient sees. You're the face of the practice, and the impression that you leave them with sets up the whole tone for the rest of their experience. So you have to remember that to make this personal with them. I started before electronic medical records came about, and I hated them. But it was, face to face. So when you're looking at the screen, typing away as you ask questions, patients sometimes feel a little bit left out of the process. So make sure that you acknowledge their concerns, look at them, engage with them. And if you display empathy, they're going to know that they've come to the right place. The history is very important. And there was a question for the last speaker about, can you tell the difference between diabetic macular edema and cystoid? And it was a great question, because you can't tell just from looking at one picture or just looking at the patient's face, exactly what's going on. You've got to get an accurate history. Like me, I tend to ramble a lot when I talk. Patients will do the same thing. So you often have to kind of bring them back on task. I did an awful lot of trauma work at the hospital here, mostly with the residents. And many times patients were very reluctant to tell you what really happened. When there's somebody in the room and they're by their side, and you can tell that they're kind of looking over, you have to suspect that there might be some abuse that has taken place, and be sensitive about that. But mostly patients want to know that their concerns are being heard. So what do you ask them? First of all, why are they there? What do they know about it? And who referred them? Because you have to be able to send letters out to the referring offices. How long has their condition been present, and how has it changed? What have they tried already, and did any of it work or not work? Okay. What medications are they taking in general? This is both prescription and over-the-counter, because a lot of over-the-counter supplements affect bleeding, and that makes a big difference, even minor procedures in the office. Has there been any pertinent family history? Do they have other ongoing medical problems, and so on and so forth? Sometimes where they work is important because they're exposed to environmental or work-related toxins, and that has an effect on the eye. Do they smoke, drink, use recreational drugs? And smoking is very important, because a big part of my practice was thyroid eye disease, and smoking is probably the single most important factor for the development of compressive optic neuropathy in these patients. So you've got to make sure you get that smoking history. Obviously, if the patient comes in with their lids split open and they're all bloody, you know there's been an injury. But sometimes there has been remote trauma that may have severed their tear duct. It was repaired, but they still tear. So you want to get that old history. If they've had any testing like CT scans, MRIs, et cetera, you want to know where they were done because you got to get the reports if they don't bring them in. And certainly, you want to know about any cosmetic procedures such as Botox, fillers, and laser resurfacing. So, of course, you start off getting the visual acuity as you would for any exam. But if the patient has any potential optic nerve compromise, and this would be especially with thyroid patients, anybody with any orbital disease, check the color vision because that's one of the most sensitive tests for optic nerve dysfunction. Make note of any lesions, facial or lid asymmetries, redness, swelling, and drainage. I mean, that stuff's pretty obvious, but make sure it's in your note. And if the patient is being seen for ptosis and or dermatochalasis, insurance is going to require a ptosis visual field. So work that into your exam. However the protocol may be, whether it's done before they're actually seen or at the end of your screening or the end of the exam, but make sure that's in the schedule. They don't want to come back a second time for a test that could be done easily that day. Now, I worked with my first nurse I was with for 25 years, and then I had two assistants that were with me probably the next 10 years. And I gave them a lot of leeway with how they handle things in the office. There's going to be a gazillion phone calls that come in during the day, whether it's from another doctor's office or more likely from patients who have questions or who have post-operative problems or whatever. I think you as the staff who are seeing the patients and screening these calls need to have a lot of flexibility in terms of how you can adjust the office schedule on your own to work urgent patients in there without having to knock on the door, wait for the surgeon, who's in the exam room to come out, ask them and fiddle around. You should be given a lot of flexibility there. There are certain conditions where you know that testing is going to have to be done. As I mentioned, for ptosis, you need a ptosis visual field. So that protocol has to be worked into the workflow, and you know ahead of time how to handle those things. I spent an awful lot of time, wasted a lot of time, always putting out other people's fires, meaning somebody calls, another office calls, and they want things done instantly. And of course, you want to please everybody and you jump right in, try to accommodate them, but that just totally screws up the rest of your schedule. So as much as possible, try to be proactive and decide how are you going to deal with problems that come up unexpectedly during the day. And this is both for the doctor, but for the staff, because it comes to you first. And remember that we all work as a team, okay? And the more we do that, the better things work. Okay, so let's move on. Every office has to determine what's appropriate to be done in the office versus taking somebody to the operating room. And again, when I say the operating room, I'm talking about an ASC or a hospital. For the office, you want to be able to do shorter procedures. You don't want to get stuck doing a 2 or 3 hour procedure there. There has to be anticipated minimal blood loss because I don't know, none of my offices had suction for that. It's just wiping and dabbing, and you don't want to get into anything too heavy. You can only do local anesthetics in the office with or without oral sedation, but you don't want to give so much that there might be respiratory compromise. As assistants, and again, I'm going to group assistants, the techs, surgical assistants, nurses. I'm put you all together for this, that all the assistants should customize instrument packs so that for office procedures, if it's a chalazion, you've got all the instruments set up in one chalazion pack. If it's a lesion, you've got lesion packs and so on and so forth. You don't want to be fumbling through drawers looking for individual peel pack instruments. It just wastes a lot of time. All the other accoutrements, shall I say, have to be available, your betadine, local anesthetics, sutures, cauteries, et cetera. And it's very helpful to have post-operative instruction sheets that are tailored for the procedures you're doing. And, that you have one that's for lid lesions, one for anything you did with the tear duct, one for a chalazion. They're generalities, but you want to be able to have them pre-printed so that when you give instructions afterwards, you review it. Okay, saves you a lot of time, and they have something to refer to. And I tried not to have totally generalized sheets that just, say take your temperature. It's like you want to make sure it's tailored to what they've had done. Now, for operating room or hospital operating room procedures, this is where longer, more complex procedures can be done, where there might be many components, upper lid, lower lid. You're fixing, many things at one time. You can give much deeper intravenous sedation. Well, that's really the anesthetist or anesthesiologist doing that. And of course, if the patient requires general anesthesia, as you would have to do for all children, it's going to be in the operating room. If you have anything where there's the potential for greater blood loss, you want it there. Anything to do with cartilage or bone has to be done in an operating room, because it's near impossible to get those areas anesthetized just with straight local anesthetic in the office. If I was going to do anything with extensive flaps or tissue grafting, and certainly if you need frozen sections for malignancies, that can only be done where the pathologist is, which is at the hospital. So lots of benign lesions come your way. I'm sorry, the top one is the pointer. Oh, works okay. I had an old laser pointer at home, and of course, I took it out of the drawer and all the batteries corroded in it. That was the end of that. But Jennifer says, we got you covered here. So papillomas and verruca are two of the more common things you'll see. A papilloma is usually in the lid margin, and eyelashes will grow through it. So patients are always worried, oh my gosh, am I going to lose my eyelashes permanently? The answer is generally no. The hair follicles for the lashes are deep in the eyelid. They're in the deeper muscle. And these lesions tend to grow from the surface of the epidermis. So they can be shaved off flush. You're going to lose the lashes temporarily, but they regrow. So just reassure the patient. Verruca are warty lesions. There's from a skin virus, and very common. Patients often have multiple ones. There's lots of fronds in it. They look pretty ugly. But they're very simple to remove. You can basically just pick them up with a forceps, snip underneath it with Westcott or curved scissors. You use radiofrequency cutters, many ways of removing them, but they're very easy to shave basically at the surface because they don't go deep. Okay, skin tags has a crazy name, acrocordon. But skin tags are very common. I used to see them on the cheek a lot. I don't think I ever saw them on the eyelid itself, but usually like over the zygoma. People get them in their armpits all the time and their back, and occasionally I would remove them if the patient was in for something with their eyelid. They'd say, oh, by the way, and it's nothing to remove them if you're already removing some others, so we would do them. Now, molluscum contagiosum is seen mostly in children, and I have to tell you, it's highly contagious. If a kid is sent in from a pediatrician with that diagnosis, or you suspect it when you first take a look at them, make sure you have gloves on, and that slit lamp has to be scoured after the end of the exam, because that virus goes everywhere and is very contagious. But these can be removed in the office if you have a cooperative patient. Oh, which button I have to push here? All kinds of cysts are seen. Now, on the left is sebaceous cyst, which is filled with the greasy oil from skin glands, from the oil glands, or inclusion cyst, which is more the epidermal layer. I didn't put a picture in here, I realized, but a hydrocystoma is filled with fluid, usually sweat, and they have kind of a bluish discoloration to it. You can just tell they're filled with fluid. They're very easy to remove in the office. I mean, after it's anesthetized, the skin is incised, and they can be shelled out or scooped out. It was always a game to see if I get it out in one piece. I would hold it up for my tech, say, there we go. But many times you'd pop, it has a very thin wall. So you just have to make sure that the entire wall is removed. Because if you leave the back surface in there, it's just going to come back in a couple of months, and the patient's a little annoyed with you. Okay. Nevi are very common. They're all different types, but the main thing is that they have well circumscribed regular borders. I mean, it's almost like a perfect circle. Same thing here. To differentiate that from some, I'm going to show you in just a moment. Junctional nevi are just within the epidermis, the surface. They stop before they get into the dermis, which is the next deeper layer. Oops. Oh, I guess I can just control with this. Sorry, there you go. Okay. Intradermal nevi, sometimes known as compound nevi, actually begin in the deeper tissue in the dermis, but they show up on the skin and they're kind of pedunculated, meaning they extend from the surface of the skin. You can kind of flap them around like boxing, I don't know what they call that thing, sit there and hit it. But these can just be, the compound or intradermal ones are just picked up and you slice it underneath it either with a scalpel or with scissors. But the junctional nevi, because they're within the epidermis, you can't just shave them off. You have to make a small incision, remove it, and then suture it closed. Xanthelasma were very common and very ugly as far as patients were concerned. They're virtually all in the medial portion of the eyelid. There was no predilection for upper or lower. Most times it's both, and it may be one side or both. They're filled with macrophages, which are cells that gobble up other things, and they gobble up cholesterol. And so these are just like pure cholesterol filled lesions. But patients always want to know, does this have anything to do with my serum cholesterol? Do I have to go get it tested? Do I need to double my atorvastatin? And the answer is no. There is zero correlation between the cholesterol deposits that these patients are unlucky enough to get and your blood levels, your blood lipid levels. So just kind of reassure them. Of course, they may have high cholesterol coincidentally. Eyelash problems are very annoying. There are two main types. One is trichiasis, which means an eyelash is growing from a normal location within the lash line, but in an abnormal direction. They can be long and curly and they grow back against the eyelashes. And a lot of the glaucoma patients who are taking latanoprost, what is it, Zalatan. I didn't treat glaucoma, but I would see patients who had abnormal skin pigmentation from it, and they also got abnormal eyelashes. They would grow very long and occasionally grow back against the eye. These can be treated easily on the spot simply by just epilating it with a forceps that is pulling them out, but they will regrow. It takes about 6 weeks for them to grow from the follicle to the surface of the skin or the eyelid. And then, of course, when they're short and stubbly, when they first come out, it's like a guy's 5 o'clock shadow. They're rough and they just scour the surface of the cornea. They're very uncomfortable. So the best treatment is electrolysis, which is easily accomplished in the office, but sometimes you can't do it right on the spot. It may not be convenient for you or for the patient. So you have to pick and choose how you do it. I don't have a picture of something similar called distichiasis, which is much less common, but it's usually a row of lashes and they're growing from an abnormal location, from the meibomian gland orifices, sometimes even from the back of the eyelid. And it's a miserable condition to get. So, okay, moving on to pre-malignant lesions. How am I doing on time? Okay. Actinic keratoses are less common than the first ones I showed you. And these are important because, well, they have a scaly, they have a scaly surface, kind of whitish, they're rough to touch. And the importance of this is that they can transform into squamous cell carcinoma. I don't know the exact percentage, and it's low, maybe 4 to 5%, but it's definitely there. And as we'll talk in a few moments, squamous cell is dangerous. Okay, keratoacanthomas were much less common. And the thing about them is they get large. They grow very rapidly. They come on suddenly. The patient will say, you know, I was fine 2 or 3 weeks ago. Then I come in with a nickel or a quarter-sized lesion on the lid or just below the eyebrow. It can grow into the lid margin and destroy the eyelid. It's a benign lesion, but there is a malignant transformation to squamous cell carcinoma if you neglect it. And these absolutely must be sent to pathology because I didn't see that many of them, but I had a couple where, I sent them in and they would say that, the borders were all fine. It was keratoacanthoma, but deep in the center was a squamous cell. So they've got to be sent. Okay. Pre-malignant lesion, melanotic lesions are seen less commonly. And as I showed you a few moments ago, the benign ones have regular borders, meaning they're fairly uniform. You don't have a million little outpouchings on it. But dysplastic nevi can be seen, and it's sometimes hard to differentiate them in the office from a melanoma. They have irregular borders, meaning, the indentations, little extensions. The pigmentation is not uniform. There's, hyperpigmentation centrally, less pigmentation there. So these are excised, has to be looked at ideally by a dermatopathologist, but any pathologist probably will be fine looking at that. The real dangerous one is a lentigo maligna, because this is a pre-melanotic lesion. They tend to be larger on the cheeks, anywhere on the face. They have very indistinct borders. Like, I can't be sure, does it end here or does it extend into this crease a little bit? There's variation in pigmentation. And I had a patient one time with a lesion perhaps a little smaller than this right over the zygoma. Well, the Mohs surgeon said, was sent in. He said, I want you to see the patient ahead of time. He does the surgery, and honest to God, he lost his whole cheek and the lower lid and his temple. And I meet the patient in the operating room. I take the bandage off and I just about fainted. It's like, how the heck am I going to fix this thing? So they can really extend. So these have to go to the Mohs surgeon. Okay. Now moving on to malignant lesions, the most common is a basal cell carcinoma. Generally, oops, I keep hitting the wrong button. They have kind of raised borders with a central area of cavitation with some pigmentation, a little bit like the shape of a volcano coming up. And they often grow into the lid margin where they destroy the eyelashes. If you see a lesion that looks similar to this, but all the eyelashes are intact, I'd be a little bit less suspicious of basal cell, but you never know. Anyway, the biopsy is done to make the diagnosis, and these are best excised in the operating room, either with frozen section control, or if you work with a Mohs surgeon, they're taking it out layer by layer, and then, secondary reconstruction the next day. Squamous cell carcinomas is one step up, and they're more dangerous because they have the potential to metastasize. I had a cousin who had a small lesion on his leg, and I heard about it. He said it was just a little tiny thing, and about a year later, he had metastases everywhere and died from it. So it happens. The treatment protocol is pretty much the same as for a basal cell. And they have more of a scaly surface over the whole surface of it, as opposed to a basal cell, which has smoother borders. But larger lesions, I definitely would send to an oncologist as well to have them check the lymph nodes and look for regional metastases. Okay. And of course, the granddaddy of them all is the melanoma. They're actually very rare on an eyelid. I only saw one in my entire career. They might be on the cheek, and I would get involved with that less frequently or occasionally. But on the eyelid, they're actually very rare. But if you see something, again, somewhat irregular borders here, variation in pigmentation, hard to tell sometimes the less pigmented ones from a dysplastic nevi and sometimes from the lentigo maligna. But these you would biopsy and then send to the Mohs surgeon to remove them all. But these have to be caught early because the pathologist looks at the depth of the lesion, how far down it goes. And a lesion that's only 0.8 millimeters, that's about a 30th of an inch, okay, may already have metastases. So that's why they're so hard to treat. Another rare lesion, something called a Merkel cell carcinoma. They tend to grow rapidly, sometimes have a purplish surface. Biopsy them, usually they lose the entire eyelid, upper or lower. They tend to metastasize with a very poor outcome. Okay, all these patients, whatever you're doing in the office, any kind of lesion, you have to anesthetize them. If you're taking out a foreign body in the cornea, well, topical anesthetic works, but most of these patients are going to have something injected. And, textbooks and my original teachers say, oh, 25 gauge subcutaneous needle is all you need. You know, that's a skin needle. And they come preloaded on TB syringes. Well, let me tell you, you take this little needle, you draw it up, and as that needle gets closer and closer to the patient's eye before you inject, well, it just grows to gigunda proportions. So you want to use the smallest needle you can. They're more expensive, but they make 34 gauge needles, and that's what I would use in the office. That's about a third the size of a 25 gauge needle and feels a lot better. So I ask, you know, what would you rather have? So use the smallest needle available. Just make sure the small ones are available. Now, in terms of injecting anesthetic, most of what the patient feels aside from the needle is either the burning sensation from lidocaine or bupivacaine, known as Marcaine, because local anesthetics have to be stored in an acidic environment, an acidic pH of about 6 to be stable in the bottle. But in order to work in the tissue, your tissue has to buffer it to about 7.5 or 8.0 pH before it even begins to work. Well, that acidic pH burns when it's injected. So you buffer it with sodium bicarbonate in the office. It's a 1:9 ratio, 1 part bicarb, 9 parts lidocaine. And if you use a small needle, it's almost imperceptible to patients as long as you do it slowly, because a lot of what they also feel is the rapid tissue expansion. If you just shove that needle in, push the plunger down and everything expands, they feel that. Conjunctiva is much more permeable than skin. You put something on the skin, nothing gets through, or at least, you know, not for a long time. But conjunctiva, if you take 4% topical lidocaine, comes in a bottle, sterile bottle, use a sterile Q-tip or, you know, cotton tip applicator. I guess I can't use the word Q-tip because it's, you know, a brand. But the cotton tip applicator, hold it on the conjunctiva corresponding to where that lesion is. You can inject through the conjunctiva, and I'm telling you, the patients hardly feel it. And it's much more gentle. It's easier to do that in the lower lid because you just pull it down. The upper lid has to be averted. It's a little harder to do that because they don't like having their lid everted, but it's a much more gentle way of injecting. Now, small lesions can sometimes just be shaved at the surface of the skin, and that's all there is to it. But if you have to incise it, meaning cutting it out, you've got to close the wound. You can do this with either sutures, which are absorbable, like 6-0 plain, or 6-0 nylon, which is non-absorbable. But keep in mind that the non-absorbable sutures for small lesions, that patient has to come back again in a week to have them taken out. Not a big deal doing it, but it's a second visit to the office for the patient, meaning more time off of work, or they got to get a babysitter for their little kids or whatever. So whenever possible, I would use absorbable sutures. Lesions that are away from the lid margin can be closed with Dermabond, and there's probably other brands of skin glue, and that works very well as long as you place it properly away from the lid margin. Now, patients would always ask me about what kind of scar am I going to get? You can't heal a wound anywhere without a scar. It's impossible. That's how the body heals. But with proper placement of the direction of a wound, you can minimize it. There's some, you know, skin tension lines. That's, you know, like the direction of all the creases. If you parallel or try to make your incision parallel to the relaxed lines, the skin scar is going to be much less noticeable than if you go perpendicular to it, where they tend to pull and they get broader. But if you pay careful attention to these lines, you can minimize scars. But let's say you do get one that's objectionable. It's red, it's thick, it's tender, it's hypertrophic, it's ugly in the wrong place. There are a number of things you can do. Triamcinolone or Kenalog can be injected in the office. You can mix it or use 5-FU by itself. It's an anti-metabolite that stops scarring. For lesions, for scars that are away from the lid margin, there are silicone-based creams that can be applied twice a day, but it's got to be for several months, but it makes a big difference. If they're on the cheek, and I know plastic surgeons would do it elsewhere in the body, there are silicone patches that are put on. It's just not easy to use it around the eyelid, but there's a lot of things you can do. but good technique goes a long way. Did I have everything on that one? Yeah. Okay. So if you're going to remove any lesion on the eye, then put a drop of Alkane in the eye first. Betadine is harmless to the eye, but it stings. And you don't want the patient squeezing their eyes constantly when you're trying to remove something because their eye is burning. So put a drop of proparacaine in first. Scalpel incisions are easy. They're very accurate, but they tend to bleed. Okay, and then you've got to sit there with the hot temp cautery, another one to keep dabbing away at it. So pick and choose your methods. If you've got a wound, remember it's got to be closed either with sutures or Dermabond. Lesions, like I showed that compound nevus before, anything that's kind of floppy, you can just pick up and shave right underneath the surface. My two favorite ways for removing lesions, though, were either the Elman radiofrequency cautery, and I don't know if anybody has had experience with them, but it's an electronic cautery which has a variety of tips that you can do a million things with. There's fine wires that work just like a scalpel. There are little round tips of various diameters that could use literally just touch and burn off small lesions. So they work great because they minimize bleeding. I also did an awful lot of surgery with the CO2 laser, and that was great. I probably wouldn't set up the laser just to remove a small verruca. It's a lot of work to get it ready, but if I was doing other bigger surgeries with the laser, it was easy to remove lesions with that. Okay. Chalasia are really, really common, and patients want it taken care of immediately. You get urgent phone calls all the time. Like, I woke up this morning, my lid's painful, I got this big mass, and I got a presentation at work this afternoon. What am I going to do? Okay, so that's where all the assistants, have to have that flexibility. Work that patient in whenever you can. Okay, the meibomian glands are the ones that secrete oil for the tears, and they're situated within tarsus. Well, the secretions get a little bit thicker. They trap microbes in there. And kaboom, you've got an abscess, which is really what a chalazion is. They get focal inflammation. It's very tender. Okay, hot compresses are used to keep it sort of liquefied, and it improves blood flow. So when you give oral antibiotics, there's more blood flow to the area for the antibiotic to be more effective. If the eye itself, the conjunctiva is very red, very inflamed, topical steroids help. But that's not the mainstay of treatment. And I tended to use oral antibiotics, not topical, because the drops don't get through the conjunctiva or the skin to get into the center of this abscess. Again, that's what a chalazion is. Treatment is really easy. You can offer steroid injections for very small ones if it's starting to calm down, but acute ones that are just juicy, the best thing is to just drain them in the office. Do the anesthetic like I described earlier. The chalazion clamp goes on, and just for the record, you got to incise through the conjunctiva. You don't want to reverse that and go through the skin. A curette is used, which is a little ice cream scooper to clean everything out. Put a pressure patch on, but if you patch them, they have to have a driver. I didn't want anybody going home driving with one eye if they weren't used to it. And let them know that there's going to be residual redness, swelling, and probably some bruising as well. They can last up to a week. So if they have that presentation in the afternoon, they're still not going to look beautiful for it. Okay. Another really common thing that I would see was ptosis and dermatochalasis. Ptosis is when the upper lid margin drops below its starting position. There's different ways of measuring it or notating it. It can be the MRD, the marginal reflex distance, that is the distance between the center of the cornea with the light and the upper lid margin. Or sometimes people would measure how far below the limbus does it extend. But there's no question you can see the difference between the two eyelids here. Dermatochalasis is when the skin fold itself sits and rests on the eyelashes or below. And the two conditions frequently coexist. Ptosis can be congenital, which is treated a whole different way than in adults, or it can be acquired. Dermatochalasis is virtually always acquired. So dermatocalasis can also affect the lower lid. Patients come in with festoons of skin and edema over the lower orbital rim, and they coexist. That you can get upper and lower as well. Well, I repaired a lot of these in the office. It depends on the patient. If you think your patient is going to be anxious and nervous and jerky, best do it with heavier sedation in the operating room, but not so much that they can't open and close their eyes to blink if they need to. Well, not blink, but I mean for you to measure the lid height. But ptosis repair is easy. A small incision, only 3 millimeters, needs to be made in the central lid crease, which is a nice landmark. You get through orbicularis muscle, the septum, and lo and behold, there's the aponeurosis. And that can be advanced or tightened with a suture and reattached to where it's supposed to be. You ask the patient to open and close their eyes as you adjust the tension, like retying your shoelace, looser or tighter to decide how high you want it to be. If they're going to have, well, there's another procedure called a Mueller's muscle resection through the back lid. I didn't like those because you couldn't adjust them. You just had to predetermine what you were going to do in the office, do it and hope it was right. So I shied away from those. Okay. But if a patient wants upper and lower blephs, and typically what would happen is I get finished talking about whatever it is they needed in their upper lid, whether it's ptosis and or bleph, they'd be out the door and they say, oh, what about my lower lids? Then the whole thing starts over again. There's another 15 minutes, when you're looking at the clock, how am I going to get out of here and stuff. But these procedures take a lot longer. I would do some in the office, but I'm telling you, it's a lot easier in an operating room because longer procedures, you can sedate them a lot better. Congenital ptosis has to be done with general anesthesia, and that's going to be in an operating room. Okay, ectropion. This is an extreme example where the lower lid is just fallen down, and you can see that the tarsoconjunctiva is exposed. Patients tear like crazy. The conjunctiva gets dry, it desiccates, it gets keratinized. Sometimes it'll crack and bleed. This is an extreme example, but ectropion is any time the lower lid begins to just fall away from the surface. So you pull the lid down, and sometimes if it doesn't snap back right away, that's an ectropion, okay? And the significance is that these patients will tear a lot. Well, it's almost always due to horizontal laxity, and they're very easily fixed through what's known as a tarsal strip, and it's kind of a busy slide, but basically a small cut is made in the lateral canthus to expose the lateral orbital rim, which is right there. It's not hard to find it in a second. The tarsus is pulled over to see how much laxity there is. A small tarsal pedicle is made, sutured with one suture to the rim, and then you close the skin. It takes about 15 minutes in the office. Okay, entropion is similar, but different. There's horizontal laxity, but there's also a vertical laxity, and that allows the lower lid to actually turn in. Sometimes it's very intermittent. Patients say, I wake up and my eye's really irritated, or if I yawn, it's really bad. If they squeeze their eyelid, orbicularis muscle overrides tarsus and it flips the lid in. It may not be there 100% of the time. So if the patient says, at different times during the day, my eye gets really irritated because they don't always know what's going on, just ask them to squeeze their eyes shut a couple of times in front of you. If there's an entropion, bang, you're going to see that thing turn in. So, quickly just pull the lid down to flip it back out. But these are easily fixed again in the office, probably takes about 30 minutes. And because you have to shorten it both horizontally and vertically. There's even a simpler one called a Quickard, after a Dr. Quickard. Suture repair takes about 10 minutes once they're anesthetized, which may or may not be a permanent solution, but I would offer that on the spot to patients just so they had immediate relief, because this is an uncomfortable condition. Patients come in tearing all the time, and there's 3 different general categories. One is they might have an underlying dry eye, and so they're making extra tears. They get that neurologic feedback and make a gush of tears to compensate for it. I've got really bad dry eyes, and I can tell you there are times my eyes are just pouring tears out because they're stinging. But there could be the lower lid malposition, that is the ectropion, full blown or just a little bit, the entropion, or there's an obstruction somewhere in the lacrimal system. So you've got to evaluate this patient. Get the history first. Do they have a history of dry eye? Are they taking any drugs known to really mess up the lacrimal system? And tamoxifen, which is used in women who have recurrent breast cancer, and I'm sure there are other uses, for other malignancies, and a lot of other chemotherapeutic agents are secreted through the tears. Okay, it gets onto the eye and tears drain through the lacrimal system where they're very erosive to the mucosa in the canaliculus and the nasolacrimal duct. And a lot of these, well, at least in breast cancer, a lot of the women would come in with tearing disorders, perhaps 2 weeks after starting tamoxifen, or known as Taxol, the brand name. So I would talk with oncologists, and I suggested to them that if they have a woman or any patient who's going to begin Taxol, to have them have a silicone stent put in beforehand, because it's misery to try to fix it afterwards. They're already sick with their underlying disease. You don't want to have to add something else to their condition. But anyway, get their history. Look for punctal stenosis, which is a very small opening, or if there's a punctal ectropion, that is, ectropion is just right where the punctum is. If the opening isn't where the tears are, there's no way tears are getting into the drainage system. Pull the lid down, see how much laxity there is. I would look in their nose, because a congested mucosa, somebody's really stuffy all the time, bad allergies, or if they have impacted turbinates, those are outpouchings on the lateral wall, that'll block the distal end of the nasolacrimal duct and causes lots of tearing. Well, you have to have an irrigating syringe ready on the counter, okay? They make very expensive irrigating cannulas, but what I used to do, and whether it was right or wrong, we would take 25 or 27 gauge needles, just cut the tip off, the pointed end, take a nail file, and just kind of burr it down, soak it in alcohol to sterilize it, put it on a syringe. You've got a 2-cent irrigating cannula that doesn't have to be cleaned and sterilized and put into a peel pack later, okay? And then you can walk right in the room and irrigate the patient if you think that's what has to be done. Of course, you put some proparacaine in the eye, a few drops first, but it's simple to flush it. And you want to see, does fluid reach the nose, meaning the whole system is open, or is there some reflux or regurgitation, either through the same lid or through the opposite lid, because that helps identify where the blockage is. And both lid problems and an obstruction can coexist at the same time. And it would be kind of embarrassing to miss a blocked tear duct and just fix their eyelid, and then you find out, oops, no, afterwards you got to fix the other one too. I think they would be kind of annoyed. To fix these things, some of them can be fixed in the office. If there's a very tiny opening that is punctal stenosis, well, a tapered punctal dilator works. They come different degrees of sharpness. Oops. That is how pointed the end is. I always like to use the really fine tipped ones. The blunt ones, you can't get in the small openings. So just work with the fine ones. But when you clean the instruments and you wrap them, these tips are very fine. They bend easily. You drop it on the counter, bang, it looks like a J hook now. So be very careful with them. But it's very easy to just go in the opening, a little forward pressure, rotating it, it dilates the punctum. You can also do this with Westcott, very fine tipped Westcott scissors after some anesthetic on there. One blade goes in the opening, the other is on the back of the lid, give a little snip, and the opening opens up. The opening itself is a sphincter like others in the body. There's encircling muscles around the opening, and what you're trying to do is cut or tear a few of those encircling muscle fibers so that it can't squeeze back down and close up immediately. It stays open. I'm sorry? Yeah, 10 minutes, as Jen said, in 10 minutes, they're out the door, they're back in the car, and it's already tearing. Okay. If there's a punctal ectropy, and here's the punctum right here, you can see my coffee shake, but there's the opening. It's not right on the eye. So a small ellipse, little excision of conjunctiva just behind the punctum, easy in the office. Okay, it takes about 10 minutes. A little ellipse of tissue is taken, a couple of sutures in there, and you have to bury the knots, meaning put them under the surface, otherwise they abrade the surface of the eye. That shortens the back of the lid, rolls that part in, okay, and that can be curative. Again, in an office. Okay, if a patient has a downstream obstruction, they can get a full-blown nasolacrimal duct, or they can have a blockage in their canaliculus. Canaliculus runs from the punctum to about the medial canthus, right about there where the lacrimal sac begins over here. Bacteria stagnate in there, mucus, dead cells all precipitate. And if they have a blockage, sometimes they'll get a stone that forms in there. Actinomyces is a bacteria that causes this. It's an extraordinarily painful condition, comes up very acutely. It's an acute abscess in the eye, in the eyelid, and these patients are howling. It's so uncomfortable. You'll often see what looks like a little abscess right at the punctum, but if you put a drop of anesthetic in, you use a couple of Q-tips, one behind and one in front of the lid, you can literally milk out stones that look, they're disgusting looking. But you can milk them out the punctum. Sometimes you have to dilate the punctum a little bit just to facilitate it. And there may be many more a little bit further downstream. So in the office, they can be dealt with. You have to dilate the punctum, and you go in with the smallest size curette. And you go in there and literally you can just kind of draw them out. If that happens, you're probably scraping, or they have raw mucosa within the canaliculus. So you put a monocanalicular stent on. Minoka makes these. They don't go down through the nasolacrimal duct. They're easy to put in right in the exam chair. You just feed it in through the punctum, and this little cap fits over the punctum and it sits in place. It can stay forever. So usually the patients start rubbing their eye later and they pick at it and they dislodge them, but hopefully they've been in maybe a week, long enough for the mucosa to start healing over so it doesn't scar shut. Because it's hard to fix a canalicular obstruction later. Oh, 5 minutes. Okay, well, I'll keep talking until you tell me to shut up. All right, dacryocystitis is also seen periodically in the office, and this is a full-blown abscess in the lacrimal sac. They can present all different ways, but again, these patients are very uncomfortable. So you anesthetize the skin. I would go in with a 10 cc syringe and an 18 gauge needle, which really looks big to the patients. I just tell them to close their eyes, but you just zap it right in the middle of that abscess and just suck it back. You can draw out as 5 cc's easily of pus from there. It decompresses it. They have immediate relief, so it's not curative, but the pressure pain is gone. You put them on oral antibiotics and then topical antibiotics, because they go inside the lacrimal system where the remaining bacteria are, and then they're likely going to need a dacryocysterinostomy later. Okay, and that's just an example of a silicone tube and a probe. If they need a dacryocysterinostomy, this is going to be done in an operating room, and I won't get into that here. Okay, so how much time?
You can do it.
Keep, okay.
Yeah.
Another part, I have a lot about cosmetic stuff. I didn't know how much time I would have, so I can cut this off whenever your next speaker's here. When I started off in practice, cosmetic procedures and surgery weren't as popular. I mean, there were blepharoplasties to be sure, but Botox was only available investigationally. One of the earlier speakers, Dr. Avila, mentioned how she would use Botox in strabismus cases. Well, that's what it was actually developed for. Dr. Scott in 1977, I don't know how he got the idea, but he purified botulinum to make the original non-Botox Botox and was used for strabismus. Well, the procedures branched out for treating blepharospasm, hemifacial spasm, complications of full facial nerve palsy, and whole host of other functional complaints. It wasn't approved and wasn't allowed to be used for cosmetics. But I think it was probably in the early 90s that Dr. Alison Carruthers in Vancouver, British Columbia, noted, I'm sure other people noticed it, but she put two and two together and realized that all these patients who were getting Botox or similar substances for all these functional components had a hell of a lot fewer wrinkles on their face. Okay, and she put two and two together and kaboom, a multi-billion-dollar cosmetic industry was born. Now there's lots of competitors. They're all similar. There are nuances between them, but they all basically do the same thing. For cosmetic reasons, you can treat crow's feet, the glabellar folds between the eyebrows, lip wrinkles, brow ptosis, forehead lines, and the list goes on, in addition to the functional component. Okay. And pretty much everybody seems to offer Botox for cosmetic reasons these days. Every medical practice, has a sign in their waiting room. We offer that. There's even kiosks in malls I've seen in Florida, and I guess it's probably a nurse giving it, but you can get fillers and even laser treatments in the mall. So it's big business. Okay, Botox comes as a powder in a sterile bottle and has to be reconstituted in the office. There's different concentrations that can be used, but the idea is you've got to keep it as concentrated as possible because there's something called Botox drift, meaning when you inject this liquid wherever it is, it's going to diffuse all around it. And sometimes, well, you get the effect, the intended effect, but sometimes it hits unintended nearby muscles, and it can be a disaster sometimes. I used to get occasional solicitations from China offering, Dr. Sir, we offer Botox, okay? And who knows what it was. It was really any kind of botulinum or what the concentration was. But with those type of preparations, there have been many patients, unfortunately, who've had systemic effects and died because they got effects elsewhere in their body and it knocked out their diaphragm and they couldn't breathe. So it's a problem. But patients can get localized effects from the things we do. You can get the so-called Spock eyebrow, which is where the lateral eyebrow was way up like this because of the wrong position being injected. When patients have blepharospasm or hemifacial spasm being treated, it's got to be injected right into the eyelid. Well, if the levator muscle catches some of it, unintended, of course, they get ptosis that lasts 3 months. Okay. Sometimes if too much is given in the eyelid, they can't blink. They can't close their eye afterwards. So you've got an exposure issue, and you can go on and on. Botox binds irreversibly to muscles, whether it's where you injected or where it drifted to. So be aware of that. But I think for patients who have functional problems, it can be life-altering, really give them their life back. Well, how much time do I have?
I don't see Dr. Ingalls.
Sitting outside.
She's sitting outside, there she is. She's here. So yeah.
Okay, well then I'll end it here. I was going to talk about fillers and maybe that'll be next year's talk. Laser resurfacing. And the final thing is, all these procedures I talked about can be done in an office. Okay, they also can be done. The bigger ones are done in an operating room. So it's up to you to decide. I say you, it's the whole team decides, is it appropriate for an office procedure to be completed, or should they be brought elsewhere? So you got to kind of feel out the patient. Are they going to be too anxious? Is it going to take too long or not? There's a few things that are usually not discussed. And this is my last point. There are other considerations about whether it should be done or not in the office. In a private office, the only fee, and I hate to sound a little bit mercenary here, but the only fee that's paid is the surgical fee. But in a hospital or a hospital-owned practice, there's a separate facility fee that covers personnel costs, all your materials, sutures, anything, and that can be those costs can be almost as much as the procedure reimbursement. So so there's a big difference if you're in a private office versus a hospital office determining where you do it. Well, I think that's probably it. I got lots more I could talk about for hours, but we're going to end it there. So how was that?
Well, thank you for the introduction. I hope everyone is able to hear me. My name is Megan Ingalls. I'm an optometrist here at the Flom Eye Institute, and I have been here for maybe close to 8 months now. Like Jen mentioned, I did my residency in corneal and contact lens care, and I really enjoy specialty lenses. So I could talk about this for days, but we're going to limit it to 40 to 50 minutes today. Maybe. It's not working.
It just works for Dr.
Rosenberg. They clicked the wrong button.
I don't know. That's what he was just making it work there.
Okay, can I just click the space bar?
Yeah.
Okay, perfect. So a couple learning objectives we're going to go over. These are all the topics that I hope to cover today. Starting with some beyond the basic skills, I would say. So these are things that y'all can accomplish in the office. I also noted them on the clinical optometric assistant outline. And so I thought it would be interesting to cover them today. And then we'll move on to some beyond the basic knowledge, just things that I think it's helpful for y'all to know to educate patients on. So my goal with you leaving today's presentation is to be able to identify and explain different types of contact lenses to patients, be able to determine / verify corneal gas permeable lenses. When I say corneal GP lenses, I'm referring to a gas permeable lens. I also may slip up and just say a GP lens. I'm referring to a corneal lens when I do that. I'll try not to, but bad habit there. And then we're also going to go over cleaning and polishing corneal GP contact lenses, and then how to perform a horizontal visible iris diameter measurement, or an HVID. Additionally, we're going to talk about the role of an anterior segment OCT and what role that plays in contact lens assessment and fitting overall. I want you to understand the role that technology-assisted fittings and impression-based fittings play in the scleral lens universe really today, and then also understanding the benefits of higher-order aberration correction. This is kind of the newest thing in the scleral lens universe, and it's something that we offer here at Flom, and so I think it's important that we all have a base-level knowledge of what it is and what it can do for patients. And then just being able to identify and explain different scleral lens insertion assistance devices to patients. Oh, it's working now. Okay. So to start off, we're going to just start with some basics here. So what are medical contact lenses? These are custom contact lenses that are fit to restore visual function or when medically indicated. The types of lenses this can include are the corneal gas permeable or GP contact lenses, hybrid lenses, scleral lenses, and custom soft contact lenses. I'm going to focus on the corneal gas permeable contact lenses and scleral lenses during this presentation, but I just wanted you to know that the others also exist. So we are going to start off with corneal gas permeable lenses. That's what you see pictured here. The reason it is glowing green would be because I put in sodium fluorescein dye to assess all these lenses on patients' eyes. And so that's why it looks like this. What is a corneal gas permeable lens? This is a small diameter lens that is less than that of the iris. It's a firm contact lens, and it lands directly on the cornea. I want you to keep that in mind. So this accounts for close to 10% of contact lens wearers today. Prior to the 1970s, this was the contact lens of choice. If you were fit in a contact lens, it was a corneal gas permeable contact lens. So why did this trend not continue, or why is it not like that today? Partially because of some initial discomfort that patients often experience when we put in a corneal gas permeable lens. Like I mentioned previously, this lens lands on the cornea, and so that's where all your nerve endings are. There's a lot of sensitivity that takes place when we land something there. And it takes some time to get used to these lenses. Oftentimes patients they don't want to be uncomfortable for that long a period of time as it's going to take for them to get used to this lens. If you notice, or if you've ever been in a fitting with me, I will always numb the patient before I put in a corneal gas permeable lens to make the process initially a little more comfortable for them, but they can't take those numbing drops home with them. There's also a significant amount of time required to successfully fit and manage these patients. There are a lot of providers within our community and across the nation that no longer offer these to patients, and we still offer them here at the Flom Eye Institute. And so I think it's important that we all realize that there's a patient base that still needs to be served that wears these lenses. And so just we will take the time and serve these patients. And then also part of the reason that these aren't as popular is because there have been a lot of innovations within the soft contact lens materials environment. In the 1970s, that's when soft contact lens materials really came to the market as being more oxygen permeable and were FDA approved. And so at that time, a lot of people who had traditionally been wearing gas permeable lenses or maybe didn't have any interest because of the discomfort started wearing lenses because soft contact lens materials really came about and were healthier for the eyes. So with all this in mind, why do we still offer corneal gas permeable contact lenses? Like I previously mentioned, there is a community of individuals who have worn these for years, and so we don't want to abandon them. But additionally, they're optically superior to pretty much any other device that you could get because they provide a smooth and uniform refracting surface. And so if you look here at image A, so you can see this is a corneal topography, which highlights areas of elevation on the corneal surface. I've kind of denoted two areas where we have some variations in elevation. The idea behind a corneal gas permeable lens being more firm is that it can create a new spherical surface. So it kind of eliminates those areas of elevation that are causing the blurred vision for the patient. Now, this is not very realistic as far as what would happen. This is an image I created, but that's the idea behind it, is we essentially neutralize all those areas of elevation. This makes them ideal for patients who have irregular corneas, so those who suffer from keratoconus, irregular astigmatism, pellucid marginal degeneration, or just corneal scarring in general. Additionally, these contact lenses prioritize ocular health. They do that by being one of the contact lenses that has the lowest incidence of bacterial keratitis, and that's what you see here in image A, and then also the lowest incidence of giant papillary conjunctivitis, and that's what you see here in image B. And I think this is important to take into account because oftentimes patients who are fit into these lenses, they're heavily dependent on their contact lenses to be visually functional. And so knowing that these contact lenses have the lowest incidence of that occurring is great to know because they're going to be wearing these lenses the most. So now that we know why, we're going to discuss what makes up a corneal gas permeable lens. So a couple of parameters. Essentially what this image is if you took a corneal gas permeable lens, turned it on its side. I think it's easier to discuss some of the parameters this way. So you always have your back vertex power of the contact lens, your overall diameter, which is denoted here by this blue, so end to end of the contact, the center thickness, which is truly the center thickness of the contact lens, and then also your base curve radius. Your base curve radius actually comes from the concave surface of the contact lens. Convex and concave is kind of confusing if you don't think about it a lot. So I have a little diameter here. Oh, the E's on the next line. Sorry about that. Okay, so this is the convex surface and this is the concave surface. Concave is caving in on you. That's how I always think about it. So it makes it a little bit easier. So all these parameters are definitely going to contribute to how the lens fits, feels, and functions for the patient. Oftentimes, patients will find us with a random GP on their eye, and they come in and they're like, I really like this lens. I want this lens again. That's great. But when I look at it, I don't know what that is. So we have to be able to verify the lens to essentially know what parameters are there so we can order another lens for the patient or we can make any changes that are needed. So that's what we're going to go over is how to verify each of these parameters for the patient, because this is really a skill that any technician could do if the equipment was there for them. Starting off, we're going to be working with a lensometer. This is something y'all work with very routinely when you're verifying glasses. The process is honestly very similar to verifying a pair of glasses with a few exceptions. One of the biggest things you need to note prior to starting this is you want to make sure you have a lens stop. This sounds kind of strange because most of them will have a lens stop, but you want to make sure the aperture or the opening of that is not super wide. You can lose the lens in the lensometer. It comes out. We just got to turn it over, shake it. I've done it before. It's fine. It comes out of there. But it's a little like it makes you a little nervous when you drop the lens in there and then you're like, oh no, this is how this patient got here. This is how they could see to drive, and now I've lost it. It comes out, so don't panic, but it's easier if you just have a lens stop to start the process. So what you're gonna do is you will dry off the lens fully. It's kind of hard to do if the lens is wet. I typically recommend a Kim wipe because tissues are a little too abrasive and can actually scratch the lens. Then you're going to place the lens so the concave side is down on the lens stop. So if the lens stop is like this, your concave surface on top of it. So the convex surface is facing you. Then you just adjust the power wheel to find out exactly how much power there is there, making sure the Meyers are in focus as possible. Typically, when you're verifying a corneal gas permeable lens, you are only going to find spherical power. Do not worry about the sill. Just because the majority of these lenses are spherical in nature. Their toric lenses do exist, but it makes it way more complicated. Just neutralize the sphere and let us know what that power is. Okay. Now, also another thing to note is when you are neutralizing these lenses, the Meyers are probably not going to be as crisp as they are when you're neutralizing a pair of glasses. They're going to get close, and that's all we're asking for. So don't worry about getting them super crisp. The next parameter we're going to discuss is the overall diameter of the lens. So this is the distance from one edge of the lens to the other. It's that blue line that was on the previous image. There are really two ways to do this. One of them is to use a diameter gauge, which is what you see here in image A. We do not have one of these at the hospital right now, but I know they have them in Brighton and Webster. This makes the process extremely easy. You literally just drop the lens into the wider area. It's going to slide down and you just read off the diameter of the lens. And then if you do not have this and you have a magnifier on hand, you're able to utilize the reticule or the measuring indicator within the magnifier to actually denote how large the lens is. Typically, if you're doing this, I would always recommend, I don't necessarily want you to start at the end where 1 is. I would rather just have you start at a whole number. So this is a very poorly aligned photo, but just start at a whole number and go whole number to wherever the lens ends. That's the easiest way to do the math on this. You're always going to denote the diameter of a gas permeable lens in millimeters. And this is important because it actually does impact the overall fit of the lens. We oftentimes forget about diameter, I feel like. We just like, oh, it's a corneal lens, it's small. Diameter is a pretty important parameter. And then this is probably the easiest thing on a gas permeable lens to verify. You do have to have a center thickness gauge. That's really the only way to do this. However, it's very easy if you do have one. So all you're going to do is put the lens between these little like pincher things here. Make sure the lens is centered in there or the best you can. And then you are going to measure to the nearest 100th millimeter. So if it says 18 on here, that's really 0.18 millimeters, and that's the center thickness. So it's the easiest thing to do. It takes like 2 seconds. You just have to have one of these in your practice. And I know we have one at Webster, and I think there's also one in Brighton. I don't know if we have one at the hospital, but yeah. And then this is probably the most complicated parameter of a gas permeable lens to verify. However, it is the most important. If I ever ask anyone to verify a GP, this is really all I primarily care about. This is what I want to know because this is directly related to both the fit and the power of the contact lens. You do have to have an instrument that you probably are not typically familiar with, which would be called a radioscope. That's what this is right here. And a radioscope, because we don't typically work with it, I'm going to go through like some basic anatomy of the radioscope, and then we'll go into the process. So to start off, you have a lens mount. That's what this thing is. It's a removable device, and it sits there. It functions to hold the lens. That's why it's called the lens mount. It's positioned on top of the stage, which is right here. And just like a microscope, the stages, you can move the stage. That's important because it will help you to center the lens when you're trying to verify things. And then you, of course, have your eyepiece, which is where you're going to look into the radioscope. You can focus that just like you can focus one on a lensometer. And then you also have your focusing knob, which is kind of similar to on your lensometer when you're adjusting to get your Meyers in focus. This process looks kind of daunting because I have all the steps on one slide, but it's easier for me just to put it all here and then we'll go through it. I promise it's not that hard. So you'll take your lens mount and then you're going to put a single, like 1 or 2 drops of saline solution into the little cup in the lens mount. You want to just keep it in this little divot here. Then what you're going to do is dry your lens off with a Kim wipe again. You want it nice and dry. And you're going to place the lens into the little divot in your lens mount that you've placed the solution in. You want to be careful to keep the solution out of the bowl of the lens, and you just want it to stay in the base of the lens mount. Once you've done this, you place your lens mount on the stage, and now we're getting started. Oh, where'd we go? Okay, perfect. Now you're going to use your focusing knob. So you're using your focusing knob and you're bringing the lens up. So you're bringing it closer to your eyepiece. So focusing, focusing, focusing until you get this star here. This is your first Meyer. This is great. If this is right in the center, you're doing great. If it's a little off to the side, move your stage so it's more so in the center. And then back to the focusing knob again. Now you're moving it away. You're going to move the lens so it's going away from the eyepiece until you see what I usually call a telephone cord. That's kind of outdated in terms of reference. So some people think it looks like a slinky or like one of those hair ties that's like curly Q. So this is your kind of like your halfway point. You're halfway there. You're doing great. Then you're going to keep going, keep moving away. You're still moving away. And now you have your last Meyer. And so this is actually the surface image. So this is your last star. At this point, if your star is still off to the side, try and get it a little more centered. Do the best you can. You want it to be as in focus as possible when you stop at this point. So since you've reached your surface image, it's time now to zero out the radioscope. When you're zeroing out the radioscope, you're either looking at a scale that is external, so meaning it's outside. Some of them will have a scale that's internal. So when you look in the eyepiece, you can see it. It's just easier to show you the one that's external here. What I've done is I've zeroed out both of the scales here. So this one here is set to 0, and this one here is set to 0. Now we're all set up and we're finally ready to read the base curve of the lens. Okay, so now we're bringing the lens closer again. We got to get back to the other Meyer, the star that we had initially, because that's what's going to tell us the actual base curve of the lens. If you don't zero out the radioscope initially, your measurements will not be accurate. So you're moving it back up, you're moving it back up. I caution you, do not just like go full force, like you got to get back to that star, because you can crush the lens. I have done that before. If you move it too fast, it'll just squish right up under there. There's no stop in these things. And so you just want to get back to that star because that one is your aerial image, which represents the actual base curve of the lens. And then you'll just read it off the scale just like you would anything else. And so what you'll do is you'll get your first value off the small here. If it's inside, it's a lot easier because it literally just 7 and then you just follow the little scale in there. It's much easier. It's less complicated. But this is your initial value. And then let's say it's 0.6. So this hand here will line up with the 6. This one would have lined up with the 7, and it's 7.6 millimeters. And that is the base curve of the lens. So a lot of steps to get to the base curve. However, when you're actually doing it, it doesn't seem like it takes that long because you're just like, oh, I got to get the star, got to get the phone cord, got to get the star again. Okay, we're good to go. So it doesn't actually take that long. And it's really helpful if a technician is able to verify a lens for the doctor because it saves me time. And then I also know what I'm working with right when I go into the room. Okay, perfect. So after you have verified the lens, you're probably going to want to clean it for the patient because you've been handling it a lot. In-office cleaning of gas permeable lenses is somewhat of a lost art, but it's something we still do here. Now, are there any contraindications or reasons that I wouldn't want to clean a lens with an abrasive cleaner in office? Yes, if that lens has hydropeg on it. Typically, we are not putting hydropeg on corneal gas permeable lenses. I say typically because that doesn't always apply. However, we are oftentimes putting hydropeg on scleral contact lenses. If the patient has this hydropeg, which is essentially an additional coating that they've paid for to put on the surface of their lens to make it more wettable, we do not want to use anything abrasive to clean that because we'll strip it right off. And like I said, they paid for that. So we don't necessarily want to take it off unless they're unhappy. When you're cleaning lenses, I just always check in the chart first to make sure that it wasn't hydropeg to begin with. As long as it wasn't, we're good to go. When cleaning the lens, I always compare it to somewhat similar to cleaning or washing your hair. You clean, you rinse, you condition. So a very similar process. Typically, we're using a red cap cleaner in office to clean the lens. The cleaner that you see here is actually something that you can't purchase to use at home. It's only something that we offer in-house. And it's very abrasive, but it does a great job of getting all the deposits off the lens. So you really don't need very much, 1 to 2 drops on the lens, and then you're going to rub it in the palm of your hand. Nice rub, turn it over, rub it again, getting everything off the lens that you don't want on there. However, you need to make sure that this cleaner is thoroughly rinsed off the lens before it goes back to the patient. So rinse it with saline super well, and then you should condition that surface of the lens to make sure, one, we took all the deposits off. Now we want to make sure it's nice and wettable again for that patient. That's the purpose of the conditioner. So you'll condition the lens. That's what you see here. Any blue cap Boston or Boston Simplex is okay to put it directly into the eye. So once you have conditioned the lens, it's okay to just store it in either some of this or just some saline solution and give it back to the patient. They can definitely put that lens directly back in their eye then. Okay, so now we've cleaned the lens, but some patients will come in and be like, can you polish my lens for me? Those are actually 2 different things. However, not all locations have the ability to polish lenses, but I think the locations that do, it's important that we understand the process. When we are polishing lenses, it does require us to have some specific supplies. These supplies include a modification unit. You're definitely going to need a sponge. You need a lens holder. Now, a lens holder is actually different than like a traditional scleral lens inserter or remover. This has a removable piece that's designed to both hold the convex and concave surface of a lens, which is helpful if you want to polish both sides of the lens. But it also has a little bit stronger suction, so it's easier to hold onto the lens when you're polishing. Then you also need some lens polish. This is different than the more abrasive cleaner because it's actually designed to modify the lens material itself rather than just clean the surface of it. The process of polishing a lens is fairly easy. You'll mount the lens on your lens holder, and then you want to make sure that sponge is nice and wet. So either running it under some water and giving it a little squeeze, or just making sure it's moist, and then place it onto the modification unit. Then you turn the unit on. Now, if you notice, you turn the unit on and then you put the polish on top of the sponge. If you do it in the opposite order, your polish is going to go all over your modification unit and it's just messier to clean up. It doesn't do anything detrimental, but it just will save you a little time. Then you put your polish on, put an ample amount of polish on there. You want the sponge to kind of be white with the polish, if you will. And then all you do is you hold your little inserter or remover and you move it up and down, moving that lens up and down with a little bit of pressure for 30 to 60 seconds. This not only cleans the lens, but it's going to polish the surface. Now, I will caution you, if you apply a lot of pressure, you can actually change the power of that lens. So be gentle. It takes less than you think. But back in the day, this is how they used to change the power of gas permeable contact lenses. Now we send everything to the lab, but we primarily are just using this to polish the surface kind of as needed. Okay, so moving on to something much bigger, and also moving on from some skills to more of knowledge level. So this is a scleral lens. I'm sure we're all somewhat familiar with those. They're traditionally much larger than corneal gas permeable lenses. Scleral lenses are defined as any lens that is fitted to vault over the entire cornea. What does that actually mean? So if you look here at this picture, you can see this is the lens, then there's this black space, and then this blue line, that's the cornea. The black space is the vault or the central clearance. People have lots of terms for it. I'm going to use vault today. Essentially what that space is the scleral lens itself is filled with saline solution prior to you putting it on your eye. That vault is the saline solution. It doesn't go anywhere. When you put that lens on, it stays there. And we definitely want to keep it there. The vault is a good thing. So we always want to have the vault. So this lens is going to vault the entire cornea and the limbus and land on the conjunctiva overlying the sclera. So we're landing much further out. So what does all that actually mean? It means the patient is going to have significantly less irritation and just knowledge of the lens being in their eye because we're fully vaulting the cornea. There has been a resurgence in popularity in these lenses within the last decade, and that's partially due to drastic changes in the gas permeable materials that we use to create these lenses. They're much more oxygen permeable today, so it's far safer to wear a scleral lens for long hours. There are a range of applications for these, and they're very similar to the applications of a corneal gas permeable lens with a few additional benefits. So you get the same optics as a corneal gas permeable lens. So that's great. Best vision you could possibly get, better than a soft lens, better than glasses. And you also get much better initial comfort because like I mentioned, we're not landing on the cornea, we're landing beyond that. So you shouldn't have that same sensation when you're blinking. You also have significantly increased stability. Why do you have that increased stability? It's partially because these lenses are highly customizable, meaning I can change just about everything about this lens. And we're going to go over all the customizations that I can make so you understand truly how customizable these lenses are for each patient. First thing we'll talk about is how I can modify the fit of these lenses. So if you look here at this picture of the lens, you can tell that these zones, they're kind of different. The light is reflecting differently in each of them. And so obviously there's some difference that exists between the variation or the different areas of this lens. The outermost curve of a scleral lens is called the landing zone. This is the most common place to make changes to a fit of a scleral lens that enhances both the comfort for the patient and elongates their wear time. So I can change the entire edge of the lens without changing any of the center portion. That's great. But what if that's not enough? Well, then we go into our transition zone. So I can also change this zone here to make it so one, it's more comfortable for the patient, but two, it's safer for the patient to wear. I can change the depth and I can change the size of this area. And then the last zone is the optic zone. So this is what overlies the actual cornea. And I can also change the depth of this and I can change the size of this to both make it safer for the patient to wear and more comfortable. However, if that's not enough, we can change each of these four quadrants individually. So I can change this quadrant and this quadrant, but leave these alone, which is great for irregular corneas because oftentimes they're not symmetrical. So just being able to change maybe these two might not be enough. I need to change just one. Well, with the innovations they've made within scleral lenses today, I can do that. One of the things that I think is really helpful when you're starting an initial fitting is to be able to know the horizontal visible iris diameter or the HVID. This is essentially the distance between the nasal and temporal limbus. It's also referred to as the corneal diameter or the white to white, which is oftentimes what we see on the pennicam, and then or limbus to limbus. It's denoted in millimeters, and there's a couple ways to gather this measurement. One of them being by hand. You can utilize a pupillary distance ruler, or you can do it with technology. Like I mentioned, the pennicam often does this, and I'm doing a pennicam prior to starting a fitting typically. However, not all locations have the pennicam, and this information may be helpful for the provider to select an initial lens. So when you're using a fancy stick like this one, you can either measure using this, or you can measure using this kind of clear gauge here. Essentially, you just tell the patient, look straight ahead, put that right in front of their eye. You're measuring essentially the iris diameter. So just how big is their iris? Okay, great. And then you write it down. Why would this matter? It matters because it helps me to determine several factors and can also help me to troubleshoot a fit a little bit easier. So the horizontal visible iris diameter here, as you can see, actually correlates pretty well with where the transition zone of a scleral lens should be. So I can change the overall diameter of the scleral lens to get that transition zone right over the HVID, if you will. I can change the transition zone depth to make it so it's deeper. Let's say if I don't have enough space to vault the HVID or how wide that HVID is, I can change the horizontal or I can change the transition zone diameter to align with the HVID without changing the overall diameter of the lens. These are all things I can do to optimize the fit if I know the HVID of a patient. And that's something that as a technician, you definitely could measure if a provider asked you to. Another helpful tool that we have to kind of help with a fitting or make a fitting more streamlined would be the anterior segment OCT. We utilize this over the top of scleral lenses typically if we're troubleshooting, but some practices will utilize this all the time. So regardless of where they're at in the fitting process, whether it's the initial lens, they're having trouble, they will always do anterior segment OCTs. I practiced in that way and then also just kind of using it as needed. It's definitely more efficient for me at this point to use it as needed, but there's nothing wrong with using it more often. When you're doing an anterior segment OCT, you do typically have to attach a special lens to the front to allow for more magnification, but most of our locations have the ability to do that. This measurement will allow us to not only determine the central clearance, but it allows us to do so down to the micron. So this is the central vault of a scleral lens. This is the cornea, this is the lens, and this is that vault space. It's telling me exactly how many microns of vault I have there, which is really helpful if my patient is struggling with something like fogging, or I'm worried there isn't enough vault in one space. I can order one of these and I can know exactly how much vault exists there down to the micron, so I can adjust it to optimize it for that patient. Another area that I find this is particularly helpful in is the limbus. So the limbus is really important. It's kind of like the Goldilocks of scleral lens fitting. You don't want to have too much. You don't want to have too little. You always need to have just the right amount of vault when you're fitting a scleral lens over the limbus. So I do find that I order these scans more often than the central ones. Now, if you look here, it's difficult to determine exactly where the limbus is on an anterior segment OCT if you haven't looked at a lot of them. This is going to be your this is going to be your limbus here and here. Okay, now if you look, this is your lens, this is your cornea, and this is the vault. We get to the limbus and there is nothing. And then it's pretty much the same story over here. These are the nasal and temporal sides of the lens. This is not good. We need to add vault there. And that the anterior segment OCT here helped me to determine that I needed to make that change. I wasn't able to visualize it behind the slit lamp, but using this technology, I could denote it here and make the change necessary. Another application of the anterior segment OCT is going to be the edge profile. When you're looking at the edge profile here, primarily what I'm looking for is to see a parallel approach. So I'm looking to see the sclera and then the edge of the lens, and I want it to be somewhat parallel, meaning I don't want the edge to be kind of pinching in. I don't want it to be flaring up. I want to make sure the edge is aligned properly. And the anterior segment OCT can allow us to do that. Now, if you noticed, I only ever gave you nasal and temporal views. Those are going to be significantly easier to gather with your anterior segment OCT than superior and inferior because of eyelids. So oftentimes, if I'm ordering one of these, I'm denoting that this is my priority, nasal, temporal. Try your best on superior, inferior, but I understand that it's difficult. Okay, so with all this in mind, what about the patient who says, I've tried scleral lenses in the past and nothing fit right? I was only able to tolerate the lens for a few hours. I've gone through all these customizations that I can make. And if the patients are still not happy with the lens or they're not able to wear it as long as they want, where do we go? Do we just tell them these are not an option? Unfortunately, this is it. Good luck. Absolutely not. So we're always making innovations and changes within the medical lens universe. And we have started to apply more technology to the fitting process. We have everything I'm going over, we have this at FLOM. So important things to keep in mind. We can do technology-assisted fittings with the use of a Penicam. A technology-assisted fitting is defined as the use of technology to design a scleral lens based upon gathering information from the cornea and the scleral. So to do this, we utilize the Penicam, which has the ability to do a corneal scleral profilometry, which is essentially like taking a topography and putting it way out onto the sclera. So elevation mapping of both the cornea and the sclera. This data can be sent directly to a lab where they can design a lens that's custom from day one for that patient. So rather than just having me put on a trial lens in office, I can do this and I can send it to the lab and that lens is customized right away when we put it on the patient's eye. Why don't we do this for everybody? Well, one, it's time consuming. If you have ever done one of these for me, you know this takes 5 scans. And it's 5 Penicam scans. So they're not fast. It's cost prohibitive. It's very expensive to design lenses this way because they are new. It's innovation. It's exciting. It's always going to cost more. And then it's also dependent upon the fixation of the patient. So if you have a patient who is very low vision without their scleral lens in or without any correction, this probably isn't a great option for them because they have to be able to fixate on a target consistently to get this data. But what does the data actually look like? So it looks somewhat traditional or somewhat like a traditional Penicam. So you have your central corneal elevation map here, but then it also gives you all of this, which is the sclera. It does so in a quadrant style fashion. And so it's doing superior, inferior, nasal, and temporal. And it's providing you all that information. I can either use this information to select an initial fitting lens, or most often what I'm doing, if I'm making the effort to do the scan or asking a technician to make the effort to do this, I'm sending all that information to the lab and letting them design a custom lens. And so when they do that, they take all the information from up here, they take all this stuff, the raw data, and they're making they're making a lens from scratch. Okay, now, this is not the only innovation we've had in the medical lens universe as far as custom fitting goes. We also have the ability to take impressions of the front surface and perform impression-based fitting. We utilize the iPrint Pro prosthetic to do this. This is really the only impression-based fitting technology that's on the market at this point. Actually, what it's utilizing, this polyvinyl siloxane material, is a dental compound. So it's very similar to what they utilize if you've ever had like a mold taken of your teeth to make a retainer. It's pretty much the same stuff. And so they will pipe that into a ocular surface applicator device. It looks like a little clear martini glass, and it is 26 millimeters wide, which is pretty darn big. But they pipe it all in there, and then they numb the patient's eye, and we stick that in, and it sits there until it gets hard. And then we take that mold and we send it to the lab. The lab is going to take a 3D scanner of that mold to determine exactly how they need to cut a lens. And so they're not like physically pouring lens material into the mold. They're using technology to scan the mold and then 3D cut a lens so that the optical quality is better. Why don't we do this on everybody? Well, it's 1, time consuming, 2, cost prohibitive, and 3, a lot of patients, I mean, if they have some sort of, let's say their eyelid is sutured shut a little bit, they have a tarsorrhaphy. That's not a good patient for this because there's no way I'm going to get that applicator device in there. They do make custom applicator devices, but they have to be custom ordered. And so there's additional costs associated with that as well. This is a great option. However, because of its highly customized nature, it's very cost prohibitive, time consuming. And so we oftentimes are turning to this as a last resort. So like I mentioned, those patients that have not been successful in other options, this is something that we're turning to get them better vision, better comfort, and ocular health overall. Now, we've gone through all these fit customizations, but that's not the end. We can customize the power of the lens as well, which is kind of common sense. You're like, of course you can customize the power, but we can do it beyond what you typically would think of. So we can do a multifocal in a scleral contact lens. So this image here is kind of a diagram of what a center near design would look like. So the reading portion would be in the center of the scleral lens, and they would have concentric rings that are designed to offer the patient both intermediate and distance vision. We also have the ability to add toricity, meaning we can correct for astigmatism that the scleral lens already doesn't correct for. So a scleral lens or a gas permeable contact lens is always going to correct for a good amount of corneal astigmatism. However, some patients have additional astigmatism correction needs based like on top of that. We can do that because these lenses are so stable because we've customized it to this point. We can essentially take their toric refraction or their astigmatism correction, and I can put that right on the front of the lens as long as I know how it's going to fit on the eye. The other cool thing that we can do with scleral lenses is we can add prism to them. There are limitations as far as how much prism I can add to a scleral lens. However, oftentimes patients who need prism are told, you're going to be in glasses the rest of your life. You have no option other than glasses to alleviate the double vision. That's not true. We can do a scleral lens with a small amount of prism. When I say a small amount, I mean usually it's limited to like less than 10 prism diopters, but we can add that to a lens to correct for any double vision they're experiencing as long as the fit is stable. The last customization we're going to discuss is kind of the newest thing in the scleral lens universe. This is called higher order aberration correction or HOA correction. So first off, to discuss this, we really need to have an understanding of what higher order aberrations are. So these are defined as optical defects that degrade the image quality. What I mean by that is, so let's say this is the 20/20 Snellen-E to somebody, they have the ability to resolve 20/20, whether it be with their glasses on or whatnot. It should be nice, crisp, clear like this. However, let's say a patient already has their glasses prescription in place, or they already have that spherical and their astigmatism correction in place. However, when they're looking at that E, it still looks like this. That's because of higher order aberrations. Those aberrations are creating blur or the inability for that image to focus on the retina. Individuals who have irregular corneas or post-refractive surgery tend to have higher levels of higher order aberration that are going to impact the quality of their vision. There's a great way to quantify exactly how much higher order aberration the patient is experiencing, and that would be to utilize an aberrometer. The aberrometer that we have here at the hospital is called the OVIT. And when we're utilizing that, it essentially will map out exactly how much and what kind of aberrations the patient is experiencing. The OVIT was actually developed here at the University of Rochester, and so it's very, very cool that we have that technology in-house as well. So this picture does a great job of depicting exactly what higher order aberration correction can do for a patient. So if you notice here in this image, those light rays are focusing all over the place. That's going to create blurred vision for the patient. However, when we add the higher order aberration correction to a scleral lens, which is essentially the inverse of whatever aberration the OVIT is picking up on, we're able to correct for that, and everything theoretically should focus on the retina. So really cool technology that just allows us to optimize the vision that a patient does have. So even if a patient isn't able to achieve the 20/20 line or their post-transplant and 20/60 is as good as it gets for them, well, let's optimize that 20/60 and make it as clear as we can for the patient. Now, this is probably one of the most important things that anybody ever said to me during residency was, it doesn't matter how good the fit is. If the patient cannot put the lens in and take it out, it's all for nothing, which is very, very true. And oftentimes we are leaving insertion and removal training up to y'all. We're not doing it. And so we're going to customize this lens. They're going to spend all this money on this lens. And then we just turn them over to you and we're like, okay, teach them how to put it in, take it out. Which if they can't wear the lens, why did we spend all the time doing that? So this is really important. And so I think it's important that y'all know all the resources that you have out there to help patients with this process. So there are a lot of insertion and removal aids available for patients. They start out with something as simple as the use of a cup and putting your scleral lens inserter in the base of a cup. That's great. It's great in a pinch. However, it's definitely not going to be the most durable option for your patient. Slight upgrade from that would be this little stand we have here. The problem I have with this stand is it's a little flimsy. It does a decent job. It does a little better than the cup, but it's kind of flimsy. It's also like $20. It's kind of expensive for what it is. A new stand that we have here would be this one down here. It just came to market less than a year ago, and it is quite a bit more sturdy than this stand. Similar price point. However, it's lower to the table, which some patients are not going to like. Another added benefit of this stand would be you can collapse it. So you can put it in it collapses down, the clear part comes off, and then it folds into a nice little case, so it's great for travel. The other stand, which is kind of like the fanciest stand that's offered, it's the most expensive, it's been around for quite some time now, is the Sea Green, which is right here. So what the Sea Green is, it's the plastic base, and then it's a light that just turns on, and you put the light in the base of the scleral lens inserter, and then you essentially just look at the light and dunk. And that's how you're putting your lens in. However, the light, I would say one of the main drawbacks of this is you can't adjust the level of the light. And you're paying like over $100 for one of these. And the light is just on or off, which I think is kind of silly. I feel like you should be able to turn the brightness up at least a little bit or turn it down based on your needs. However, a lot of patients will use just the plastic stand and they don't utilize this device here, the light. So it's entirely up to them. Some people need the light right away and then they don't need it anymore after that. The perk of using one of these stands is it gives patients control of both eyelids. So they can use both hands to open the eyelid and then put the lens in that way, which is great for individuals who have very sensitive eyelids and that are struggling with insertion of a scleral lens. One of the coolest innovations that has come about in scleral lens insertion and removal is the robot that a patient actually developed. So this patient wears scleral lenses, and he noticed that there were a lot of other individuals in the office that were struggling to put in their lenses and remove them. And so he developed a robot that actually has the ability to sense pressure, meaning it can not only put the lens in, it can also take the lens out for the patient. There's kind of two versions at this point. I don't necessarily entirely understand how the manual version operates, but I have seen the electronic version. It's kind of slow, and you are still limited, and the patient would have to be able to hold the eyelid open. But beyond that, it does the rest of the work. It's pretty cool, and it does a good job of sensing pressure. It's not applying an excess amount of pressure on the patient's eye. I have a link in here, but it's a Facebook link. I don't think it's going to work. But when I share the slides, if you wanted to look at the video, that way you can. Also, I didn't know if everybody would want to see that. So, but that's essentially the newest innovation in insertion and removal training. So there's absolutely no patient that really, as long as they can hold their eyelids open, we can put a scleral lens on them, even if they're really struggling in office. And then this was just a review I was gonna do of in-office lens disinfection, but we're pretty much like full on time. So questions?